Welcome to this explainer on research methodology. I am VSI, created by Dr. Mohammed Omar El Farouk. And today, I'm summarizing this absolutely crucial chapter on epidemiology and clinical research, specifically tailored for you, the vascular surgeons. Our goal here is pretty simple. We want to help you turn raw data into a vital surgical instrument for your everyday practice. So let's just dive right in. Here's a quick look at our roadmap for today. We'll start with the foundations of vascular epidemiology, move into designing clinical studies, then understanding bias and outcomes, touch on advanced survival and analytics, and finally wrap up with evidence in vascular practice. All right, part 1, Foundations of Vascular Epidemiology. You know, every meaningful research project out there starts with fundamental clinical questions. Why do vein grafts fail? When is an aneurysm actually at risk of rupture? What size graft should you use? These really aren't just academic exercises. These are the exact questions you face in the operating room in the clinic every single day, right? Which treatment option is going to be best for the patient sitting right in front of you? Well, to answer that with any certainty, we need a structured approach. And to get those answers, we rely on epidemiology. Now, this practice has evolved a ton over the years. It started way back in antiquity with Hippocrates, who was really among the first to even contemplate external disease factors. Then, fast forward to 1854, and you have John Snow's brilliant geographic mapping of cholera cases at the Broad Street Pump. Today, in the modern era, we've obviously traded pencil and paper for massive, terabyte-bearing international registries like the Vascular Quality Initiative, along with some pretty advanced machine learning algorithms. But honestly, the core principle remains exactly the same. We are trying to understand how and why diseases manifest in populations. So before you can even think about designing a study, you absolutely must understand your disease's frequency. It's crucial to distinguish between two main concepts here. Prevalence is basically your snapshot. It's the ratio of persons affected at a single point in time. It's fantastic for studying long-duration diseases, but for short-duration or high-mortality conditions, prevalence kind of falls short because it misses patients who either quickly recovered or, unfortunately, passed away from it. That is exactly where incidence comes in. Incidence tracks the new cases developing within a specified period. It's more of a running ticker. Okay, moving on to Section 2, Designing Clinical Studies. The very first major fork in the road when you're setting up a study is choosing between observational and experimental designs. Observational studies, like your cohorts or case controls, simply watch ongoing treatments without actually intervening. They are incredibly useful for identifying risk factors, calculating odds ratios, or studying super rare conditions using those large registries we talked about. Experimental studies, on the flip side, proactively introduce a new exposure or treatment to test a hypothesis. And this, of course, is where randomized controlled trials, or RCTs, live. By randomizing patients, we can evenly distribute both the known and the unknown confounding factors, which helps us avoid bias. A really landmark example of experimental design in our specific field is the OVER trial. This randomized over 800 patients to either endovascular aneurysm repair, EVAR, or open surgical repair. When tracking the data over time, it's amazing to see how closely the survival curves for those two groups track together. The study ultimately found that overall survival at 14 years of follow-up was remarkably similar between the two interventions. This is exactly the kind of high-level, rigorous evidence that directly shapes our clinical practice guidelines. Let's transition to Section 3, Understanding Bias and Outcomes. As researchers, we have to be incredibly vigilant against systematic errors, which we usually just call bias. Random error is just natural variation, we expect that, but systematic error pushes your results in one unintended, completely false direction. For instance, selection bias happens when study participants fundamentally differ from non-participants, like if healthier patients are self-selecting into a trial. But I really want to highlight confounding by indication. This is a massive, massive trap in observational studies. It's when patients treated with a specific drug or surgery show worse outcomes. And you might think the treatment is bad, but why did it actually happen? Simply because those patients were much sicker at baseline, which is why they required that heavy-duty intervention in the first place. Another major pitfall happens when we try to synthesize multiple different studies into a meta-analysis. We always have to test for publication bias. This is the somewhat unfortunate reality that studies with non-significant or, let's say, boring results often just remain unpublished. They end up in a drawer somewhere. If we only analyze published data, our results are going to be artificially skewed towards successful interventions. So we test for this graphically using what's called a funnel plot or statistically using Begg's test, basically looking for missing data points that suggest those unpublished negative trials are hiding in the shadows. When we do synthesize multiple studies into a meta-analysis, we use forest plots to pool the effect sizes together. Take aspirin use during non-cardiac surgery, for example. By combining a bunch of smaller studies, we can significantly decrease sampling error and vastly increase our statistical power. When you map this out, you'll see a confidence interval for each individual study weighted by its size, all rolling up into one master conclusion. Synthesizing data this way is just brilliant for clarifying those disparate, conflicting results you sometimes get from smaller independent trials. All right, let's get into the math. Section 4, Advanced Survival and Analytics. When you're determining how to actually prove a statistical difference between groups, picking the right test depends entirely on your data type. Think of this as your quick cheat sheet. If you have parametric, normally distributed data, comparing 2 groups means you use a t-test. 3 or more groups, you're using a NOVA. If your data is non-parametric, you shift over to Wilcoxon or Kruskal-Wallis. And for simple proportions, you're looking at chi-squared or Fisher's exact tests. Having this mental framework takes the guesswork completely out of hypothesis testing. Now, in vascular surgery, graft patency over time is basically everything. We don't just care if a graft failed, we really care exactly when it failed. We analyze this time to event data using 2 main methods. First, life tables. These measure events at predetermined fixed intervals, say checking in every 30 days. But the Kaplan-Meier method, which you see all the time in our literature, captures each event precisely at the exact time of occurrence, day by day. And the great thing is, both uniquely handle censorship, meaning they mathematically account for patients who might drop out of the study or pass away from unrelated causes before their graft ever actually fails. Looking forward, machine learning techniques, specifically random forest modeling, are emerging as incredibly powerful predictive tools for us. By mapping out variable importance, the predictive accuracy of these models just skyrockets. For example, the prediction error rate for amputation drops from 63% with traditional logistic regression all the way down to 31% when using a random forest model. It literally cuts the prediction error for death in half. As a vascular surgeon, having predictive models that are this much more accurate is an absolute game changer for how we counsel our patients. Finally, let's bring it all together in Section 5, Evidence in Vascular Practice. A major part of evidence-based practice today involves cost-effectiveness analysis. We look at new treatments based on the dollars spent per quality-adjusted life year, or QAYL gained. In the US, new treatments are very often evaluated against a threshold of roughly $60,000 per QAYL. Do you actually know where that specific number comes from? It's a really interesting benchmark that was historically derived from the calculated average annual cost of hemodialysis for renal failure patients. Basically, if a new intervention costs less than $60,000 to grant a patient 1 additional year of perfect health, it's generally considered a highly cost-effective move. Ultimately, we take all of this, the RCTs, the meta-analyses, the economic data, and we synthesize it into grades of recommendation. This gives us a standardized framework to actually guide our clinical practice. Grade A represents strong evidence, backed by consistent level 1 studies, like well-executed RCTs. And it scales all the way down to Grade D, where evidence is just insufficient or heavily conflicting, meaning we're relying mostly on expert opinion rather than rigorous trials. Relying purely on our personal experience biases our decisions, but these frameworks keep our practice firmly anchored in objective reality. So I want to leave you with this final, somewhat provocative thought. As vascular surgery rapidly advances with crazy endovascular innovations and new machine learning models, how are you going to use this methodological toolkit? Healthcare is a wide continuum, stretching all the way from basic sciences up to national policy. You can choose to just read the guidelines when they come out, sure. Or you can use these tools to design better studies, identify those unseen biases, and actively shape the future of patient care yourself. The choice is completely yours. Thank you so much for joining me on this explainer.